Bon dia, good morning, everyone. Hello, hello, can you hear me well? So please, I'm just introducing, welcome to stage Alpa and Caoimhe from St. Thomas in London, and good morning, everyone.
Thank you very much. Can you hear me? Can you? Okay. Today we're going to be talking about our use of DEBRICHEM and our experience. A bit closer? Okay. So my name's Alpa Lakhani and I'm one of the lead podiatrists at St. Thomas's Hospital, and this is my colleague Caoimhe, who's an inpatient podiatrist vascular. So we are based in London and we have two major hospitals that we work in, and we treat inpatients and outpatients, and 2 MDTs for inpatients and 2 for outpatients weekly, and it's a really busy clinics. So we all know that foot ulcers have a huge impact on the NHS. We know that at least 1% of the NHS total budget goes on foot ulcers. So anything we can do to improve the cost of these, we are going to try and do. The other thing is that anybody with a diabetic foot ulcer has about 8 days extra in hospital. So anything that can reduce bed stays will reduce costs. So we will also be looking at cost in everything we do. So standard in wound healing includes wound care, vascular control, infection, offloading, and metabolic control. It all has to work in a jigsaw. It's not just one thing. And unless you've got every bit of the jigsaw together, the wounds are not going to heal. So today we're going to be talking about wound care and in particular debridement. Debridement is the most important part of the wound care. So debridement involves removing devitalized tissue and reducing it back to healthy granulating tissue, removing biofilm around the wound. So obviously there's lots of types of debridement. We are going to be talking today about chemical debridement, but to say that the most important thing is this is not to replace sharp debridement. But in some cases, sharp debridement, you may not have the staff who have got the experience to do sharp debridement, or the wounds are too painful. We being a vascular hub, we see a lot of patients who have severe vascular disease and their wounds are so painful that we're not able to debride. So this is another option. As I've said, the guidelines say that sharp debridement is standard practice, and this is no way to replace that, and I would like to stress that. But in specific situations, chemical debridement is an option. So because, as I mentioned, we are a vascular hub, we do have patients with very severe vascular disease, and we're at the end of their limb, there's lots of limb salvage going on. The patients are in severe pain, and I think we've lost it, haven't we?
There's a problem inside, just keep on going.
Okay.
It takes 2 seconds.
Okay. So whatever we do to deslough and debride the wound, it has to be quick, and sometimes sharp debridement doesn't always work in that it just resloughs and resloughs. And we also need to get patients home. So my colleague now is going to take over and give you some of our case studies.
Which one do I press? This one? Yeah. Okay, so I'm going to talk about our experience with using DEBRICHEM. We started using it in Guy's and St. Thomas's last year, and I'll go through a few cases and explain a little bit about DEBRICHEM. So DEBRICHEM, I suppose, desiccates the wound and will help to destroy biofilm and pathogens and help to promote wound healing by kind of stimulating granulation tissue. The other benefits is that we find it's very easy and fast to use, that we apply it for 60 seconds on a wound and then wash it off. And we don't need to, it's a single application, so we don't need to come back the next day and reapply it. patients can have it applied and then go home. And it's also safe to use on intact skin. So I suppose this is just a little video of DEBRICHEM being applied over a biofilm layer and destroying the biofilm and pathogens, and then leaving the granulation tissue to breed and I suppose promote healing from a wound from that perspective. So moving on to our cases. So our first case study is he's an 85-year-old male who was admitted with a necrotic foot. He had a transmetatarsal amputation and had a revascularization as well. He's a quite complex history, so they didn't want to bring him back in for any further debridement, and his blood supply was optimized as best as it could. So it was quite a sloughy wound. Myself and Alpa would debride it, but it was quite painful, so we put a bit of lidocaine around the area to help with the pain. But we'd come back and it would be re-sloughed again 1 week later. And we did this on 2 occasions and it happened again. So we used DEBRICHEM on the area, and this is 1 week post, and you can see that there's some kind of islets of granulation tissue coming through, and that actually didn't re-slough, so that was really beneficial for us. And he was in far less pain as well, which was great as we kind of were doing further with the wound. So then we actually we wanted a clean base to apply Stimulin on this wound. And we felt that DEBRICHEM really gave us a clean base to apply it. And you can see when we applied the Stimulin 3 weeks later that the wound bed had decreased in size, and DEBRICHEM had a big part to play in that. And he got to go home, which was fantastic. Next case was a lady, she's about 70 years old, hallux amputation, revast. And when she was in hospital, I tried to debride her wound, very painful. We put larvae therapy on, and it helped, but didn't give us the results that we really wanted. So she was seen in outpatients, and you can see there's a lot of hypergranulation tissue around her wound. She'd no osteomyelitis on her x-ray, she wasn't on any antibiotics, so we used DEBRICHEM on her wound. So this was 1 week afterwards, so you can see that carbonization of the biofilm on it there. And I suppose 2 weeks later, that hypergranulation tissue has really gone down, and you can see it's more healthier granulation tissue coming through. And she was in far less pain as well, so we could do a lot more with her wound. And this is 4 weeks later, then more granulation tissue coming through and a lot healthier, her wound, and it decreasing in size as well. With this wound, we did dry dressings with this wound, so we didn't put a vac on it, we put dry dressings on top of this wound. And our last case, so looking at an acute wound, a gentleman who had a first and second digit amputation. His wound was quite devitalized, and the vascular team did a duplex scan. There was no occlusions or stenosis, so we said we'd try some DEBRICHEM on his wound. So this is 2 days post applying the DEBRICHEM, and you can see that darkened area which is meant to happen with the DEBRICHEM, and this, I suppose, kind of brings to the importance of communicating with the teams to tell them that you're putting DEBRICHEM on, because it can make it look a bit scary and it make it look a bit worse, but it actually isn't at all. It's all working perfectly. So his wound, really the granulation tissue really started to come through this gentleman's wound as the weeks went on, and the wound decreased in size and more granulation tissue coming through. We put a vac on his wound, which worked really well. So I suppose looking at any adverse effects, so we had no significant adverse effects in the cases that we've used DEBRICHEM on. There's been a decrease in pain in the patients that were, I suppose, had ischemic wounds in nature, and no further surgery. So no patients we applied DEBRICHEM on had to be readmitted to hospital for any further surgical interventions to do with their wounds or for any infection. So I suppose our top tips from our experience of using DEBRICHEM is that sometimes the wounds might look worse from that picture in case number 3 before it starts to granulate, and it's really important to communicate with teams that that is the case and that's normal how it looks. As Alpa said, it's best when everything is optimized, when the vascular supply, the offloading, infection, metabolic control is all working in harmony. It's not a replacement for surgical debridement of a wound, but it is a good alternative to larvae therapy, and it can reduce bed stays. So we found that patients we applied it on could go home the next day as opposed to having to stay in hospital for further treatment. And I suppose we're now looking at all our cases, and we're excited to see the long-term outcomes of using the DEBRICHEM therapy. And that's it. Thank you. Any questions?